Hey, good morning, good afternoon, and good evening, everyone. Hopefully everyone can hear me. Welcome to the Local Partners presentation on going the last mile to close the gaps in pediatric treatment. My name is Lita Joaney, and I'm a program analyst in the pediatric and maternal branch within the Office of HIV/AIDS. I am going to be moderating this technical session, and I am accompanied by my colleague, Nicole Buono, who is a senior HIV treatment advisor in the pediatric and maternal branch as well. And she has kindly offered to be our note taker for the session. Before I introduce the three panelists, I'd like to quickly just go over some logistics for this call. As you probably know, there's a chat box at the bottom of your screen that we will be monitoring. So please feel free to drop in your questions during the presentations, and we'll make sure that they're answered during the Q&A portion of the call, which will happen towards the end. There's also a translation function in Zoom. So if you click on the word interpretation at the bottom of your screen, it has a globe icon next to it. You can hear today's session in the language that you select. And of course, if you have any logistical questions throughout the presentation, please drop them in the chat and someone from Tech Change should be able to help you out. Finally, please remember to keep yourself on mute and off video unless you're presenting in today's session. So today's session objective is to share best practices and lessons learned on the implementation of pediatric ART. And we have invited three local partners to speak on this subject. First, we have Dr. Hamid Mandali, who is the country program lead at Mothers to Mothers in Lesotho. Hamid is a physician by training and an established public health specialist and has over 14 years of experience in the health sector, providing clinical research, programmatic, technical, strategic, and decision-making leadership to donor-funded projects. He's currently leading the comprehensive PMTCT program at M2M, which includes care and treatment, HIV testing services, and DREAMS activities. Welcome, Hamid. Thanks for coming on camera. Next, we have Dr. Carol Tate, who is the project advisor at Inova Health Institute in South Africa. She currently leads the Pediatric and Adolescent Scale-Up and Unfinished Business Project, which focuses on supporting the health system to improve care for children and adolescents living with HIV. Before starting her current project, she previously worked as a PMTCT clinical advisor, as well as in hospitals and clinics around Johannesburg. Welcome, Carol. Last but not least, we have Malundu Mumbalanga, who is the HTS Regional Coordinator at Right to Care in Zambia. Before joining Right to Care, Malundu held the position of Research Supervisor on the evaluation of cost involvement and estimation in maternal and newborn interventions under Systems for Better Health at the University of Zambia. I think Melinda is having some difficulties joining the call, but hopefully she will be joining us very soon. So thank you all for joining us today and being willing to present on such an important topic. And thank you to the audience for tuning in. If anyone in the audience is interested, you can read Hamid, Carol, and Melinda's full bios on the conference meeting platform. So I'll go ahead and turn it over to Hamid for our first presentation on Lesotho's EMTCT detectives. Over to you, Hamid.
Thank you, Lida. Hello, everyone. Thank you for joining our panel. I'll take you through a work that has been done by a strong M2M team in Lesotho with the guidance and the collaboration from the Ministry of Health and support from PEPFAR USAID. We are sharing the work of mentor mothers towards elimination of mother-to-child transmission, especially for HIV. Next slide. Our presentation will have a background of our work and methodology that we use for this abstract, and also we'll share with you results from our analysis. We'll share also interpretation. We'll share a snapshot of our service integration that we are doing our work holistically. But also, much as our work has been successful, we had some challenges here and there, but we came up with some remedial actions to correct them. And then we'll share lastly our conclusions with a snap of recommendation. Next slide. Yeah, you can see from the picture as we work, our team working to the last mile to make sure that they are going to serve hard to reach communities, especially targeted clients of ours, with comprehensive services. You can see from the picture, our team members, they've got backpacks to make sure that they have everything they need. Once they serve a client, they serve them holistically. Next slide. So we know normally it's in epidemic like HIV, women are still hit harder by the transmission and infection. And then this way threatens a challenge to the unborn babies, but also their infants. Knowing this, our mentor mothers, the cadre that is spearheading our work, they are working tirelessly to make sure that this targeted group receive necessary services, necessary support to make sure that the threat is not cascaded further to their unborn babies and infants. And their work is offered in all levels, from facility, community to household levels. And they approach the services and further support to our clients in different ways. They're using a face-to-face approach where they do one-on-one interaction, but also they conduct peer via phone call approach to make sure that our clients are supported each and every time. Next slide. So in our analysis in this abstract, we try to share with you analysis from 31 sites that we are working currently in Mafeteng and Moalesuk in Lesotho, just to share a snapshot where we are not directly involved to offer comprehensive PMCC services, and when we were involved to offer PMCC services. And the results will be shared through graphs presentation. But basically, the enrollment of targeted clients accessing comprehensive PMC services has remarkably improved. You can see from the numbers with 8 quarters, FY18 up to FY19, complete 2 years, the enrollment in these areas where we work was 6,719. But in only 7 quarters, as we analyzed our data, you could see the enrollment has gone up almost by 2,000 extra. So involvement of mentor mothers has contributed a lot into this greater uptake and scaling up of our comprehensive PMC services. Next slide. So with this graph, we're sharing an appreciated improvement, especially in enrollment of ANC1 clients. You could see by numbers, we were increasing as we move more to the right, but much as the enrollment has gone up, still we maintained the known status of our ANC clients. So every client who's served by mothers to mothers, they know their status, and this helps a lot in our support to them. Much as the enrollment has increased, but also them knowing their status has been maintained by 100%. Next slide. In this slide and the graph, we share an achievement, especially in AID services uptake to our infants who are kids of our clients, but mostly important, the EID services where mothers to mothers work, the uptake is higher within 2 months of life. So you can see our clients where we work, 96% of our infants who are exposed, they've been able to access EID services within 2 months of life. Next slide. The numbers you can see from this cascade through our mentor mothers who are frontline workers for us, much as there was some significant trend in eliminating mother to child transmission. When we were directly involved and through mentor mothers, We've been appreciating the outcomes of their efforts, especially when we test clients who are exposed. And as we sit now, when we analyze the last quarter of April to June, the mother to transmission rate is sitting at 1%, and we're still working harder to make sure that we try all means to eliminate transmission of mother to child for HIV. Next slide. As we offer services to our clients, we must make sure that we really get the results and we document. So you can see when we joined to offer comprehensive services as mothers to mothers, we found the documentation of final outcome sitting around 72. And then when we put our effort through mentor mothers, we went up to 81%. And just this year, I think that from the final APR, we've gone way up from 81 to 88. So our mentor mothers are driving the effort to make sure that results are available and documentation is done properly so that we can intervene where we feel like we are challenged. Next slide. So in this slide, we're sharing basically the suppression rate. Like I said initially, the enrollment has been upward. We maintain to make sure that our ANC1 clients know their status, and those who are HIV positive are initiated on ART immediately. And mentor mother, they work together with these clients as a team to make sure that these clients still remain on care. So when our clients remain on care, that is when suppression is achieved. So you can see we have an average of 98% suppression rate to our clients. Next slide. So tremendously to share with you the results since the engagement of our mentor mothers through our M2M program, with the collaboration with other partners and the guidance from the Ministry of Health. Our mentor mothers who are EMTCT detectives, statistically, the results have been so significant. Like I shared initially, 100% of our ANC clients know their status. There's an increase of uptake of EID, especially within 2 months, but also the suppression rate, you can appreciate it was around 98%. So involvement of our mentor mothers really is a driving force to these results. And we are proud to share with you that our mentor mothers are the engineer of EMTCT within Lesotho. Next slide. So our services are not working in silo. We are trying to make sure that we put in place where we offer service or comprehensive interventions that will drive and contribute to epidemic control. So much as we offer PMTC program services, but when we say we offer comprehensive services, we include also GBV services, we also include OVC services, but also we play a role in TB prevention by offering TPT. So our clients benefit holistically from our approach. Next slide. It has not been a smooth journey. We've been challenged. The geography in the country is sometimes make it so difficult to reach some clients. So our teams, driven by our mentor mothers, they have planned community outreaches where they even visit household to support our clients. When some clients are not reachable, we have formed collaboration with village health workers where we work, but also we work with other partners to make sure that our clients are reached and we serve them. We had an issue in the country where viral load was focused only on adults, and mothers to mothers, we played a role in advocacy to involve infants and children, and that has worked. And currently, as we speak, the country is rolling out POC viral load to include all targeted age groups, but also as mothers to mothers, since we have frontline health workers who are mentor mothers, they're trained to run these POC machines so that they can offer closely the services, but also share the results with our clients. Next slide. So as we conclude our abstract presentation, I would like to share with you that Mentor Mothers have been supporting clinical services through community facility and household interaction approaches that caters health education, demand creation, and linkages. And this has contributed a lot from the results that we have shared with you where we work, and also has contributed to the lowered MTCT rate in Mafeteng and Moalisuk in 31 sites that we work. We believe strengthening our Mentor Mothers, and now we've digitalized our services, will make sure that EMTCT is achieved through these EMTCT detectives on daily basis. So we propose a scaling up of the same model. This model is only implemented in 2 districts of Mafeteng and Moalisuk. So if this model will be replicated to other districts, I think, and we believe that the country will achieve EMTC rate uniformly, and thus Mentor Mothers will be a great champion for EMTC in the country. With that being said, I would like to thank Ministry of Health in Lesotho, especially the Disease Control Directorate, PMTC program, PEPFAR USAID, my strong team, Mothers to Mothers, Lesotho and head office, but also thanks to other implementing partners, because where we work with other implementing partners. I would like to end here and welcome Dr. Carol Tate. Thank you.
Thanks so much, Hamid. Just a reminder before we move on to Carol to please put your questions in the chat box. We already received one really good one. So please keep them coming so we can answer them towards the end. Over to you, Carol.
Thanks so much, Lida, and good day, everyone. Thanks so much to the organizers for this opportunity to present on our experience in Johannesburg of supporting children and adolescents living with HIV through our clinic community collaboration and bidirectional referrals. Next slide, thanks. So we know that in South Africa, we have a high number of children and adolescents living with HIV. And we know we have also made significant gains in mother-to-child transmission reduction and improving ART access, both for adults and children. However, we see that we still only have just over half of our children and adolescents living with HIV on treatment. We see that we need considerable efforts to reduce treatment interruptions and disengagements from care to be able to improve this treatment coverage. To support retention and suppression, a comprehensive approach is needed due to the multiple factors that affect adherence. In this ecological model, you can see the factors that could be divided into individual factors, factors around families and relationships, the community that the person is in, and overall structural factors. So from this, you can see that a biomedical or health facility-focused approach will really not get us there for many of our patients to overcome their retention barriers. Next slide. Community-based programs supporting orphans and vulnerable children are well positioned to overcome many of these barriers. They offer services that help our young people stay healthy, and this is particularly around HIV care and treatment, but also other care. They help families and young people to be more stable, particularly around economic strengthening and helping them to build resilience in their families. They also help with safety, reducing and mitigating violence against children and gender-based violence. And they also help our young people to remain at school, both primary and high school, and providing other vocational training as needed. In our setting, which is in Johannesburg, we had an enabling environment to access this kind of support. We had several community partners available, and these are OVC-funded partners who implement services directly in communities or by supporting other local community-based organizations. We also had our leadership who was supportive of our engagement, and we had good progress in the past when we had implemented this on a small scale. However, what we saw is that our process was not formalized across our partners and facilities, and there were few referrals and limited monitoring. So what we aim to do as part of our broader supports for our peds and adolescent programming was to improve clinic and community collaboration in one of our districts in South Africa. And we wanted to formalize the process and increase the number of referrals so that we could overcome retention barriers for more of our children and adolescents. Next slide. So we saw that this was an ongoing process that required ongoing engagement, and it was driven by a champion. So we assigned a dedicated technical advisor to focus on strengthening this collaboration, and that was at the district level, so they supported overall. We also had extensive engagement, both internal and external, with our different partners and our teams to gain a better understanding of their activities, their processes, tools, and all of their ways that they would function. We also needed to enhance existing platforms so that we streamlined them and also created new platforms where we could collaborate. We spent a lot of time as teams defining our processes, and this was done with our community partners. We mapped their activities and their geographical areas of support. We looked at the referral pathways, how we wanted to monitor the process, and we also looked at all the different tools that were available for referrals as well as tracking. We saw that this was not a once-off process, and we had to engage on an ongoing basis and make adaptations as needed. So for example, during COVID, we needed to move to telephonic and virtual engagement and support. We refined our tools and processes as we used them and saw where they needed to improve. And we also needed to update our partner mapping as things changed along the way. Next slide. So I've just put some of our examples of the tools and processes that we reviewed as teams, and this was done as a collaboration with ourselves and our community partners. So the first is an example of our facility to community referral pathway. And you can see at the top, there's the steps that the patient would take to be referred from the clinic to the community partner, which person was responsible for these activities, and then also which tools and monitoring registers could be used to monitor the process better. The second picture is an example of our partner directory. And here we went into quite specific detail about where the partners were placed, if they had any sub-awardees that were implementing, which age groups they worked with, which activities they ran, and also which facilities they worked with. So we use this mapping to be able to work better in the different areas in the district. Next slide. And then this is one of our tools that we designed. This is our referral tracking tool. One of the biggest challenges was that we weren't able to monitor the number of referrals that took place and also whether the person that was referred actually reached the referral site. So we designed this tool with the partners. It's got the patient information and details about where they were referred from and to. And then as you can see, it's got the different sections which have all the different services that the young person might need to access. And then highlighted in yellow, we could choose whether the person had been linked to the service, so whether they were successfully linked or whether the referral was still pending. And this way we're able to better follow up our referrals and also monitor the number of referrals better. Next slide. And then lastly, in our methods, we also worked on a case conferencing approach where we know that for complex cases, we wanted to discuss them together as partners to plan and monitor their care better and ensure that they got more comprehensive care. So the process flow is an example of how this was done. So in this case, for example, a patient with an unsuppressed viral load, the person would be identified and then the case conference would be facilitated. And the different activities would be decided upon and tasks were allocated to different team members with their different time frames. And then feedback sessions were held to be able to monitor progress and any further challenges and other activities that needed to be done. And part of this, we also designed a case conferencing form from the different forms that partners had so that we would have a standardized form to use in our case conferences. And this is just a simple form to help our teams document what was discussed in the case conference and be able to follow up and hold each other accountable for the activities that were assigned during the case conference. Next slide. In terms of our results, this diagram shows the progress that we made over a period of 1 year. So you can see it's divided into the facility to the community, represented here by the CBO, community-based organization, as well as referrals from the CBO or community back to the facility. So in terms of the facility to the community, we referred mainly directly to community organizations or CBOs for their community-based case management, the services that I've mentioned in the beginning. And we referred over 1,000 of our children and adolescents to these services. And then a smaller number of these, 96 of these, were discussed through case conferencing, and these were our more complex cases that needed more of that approach. On the other side, we have our community to facility flow, and there were two main methods for this. The one was directly to facilities for other facility-based services, clinical services, and you can see a lower number of referrals in this category. The main mode of referrals from community to facility was for HIV testing and PrEP. And in our case, we were actually able to offer a facility outreach team, which could come to the community-based organization. So it worked very well, where the community-based organization would see which of their beneficiaries needed the service, and then we would bring our outreach team to offer the service directly. And we're able to test just over 1,800 children and adolescents. And this was the majority of our overall community approach. And then of these, we were able to initiate 441 on PrEP, and then they were linked back to the facility for further care. Next slide. Some more results. So this is a graph of our results over time, and it shows the ups and downs of the process and the progress that we made. And you can obviously understand that there were many factors last year that affected performance. So this shows how we were impacted by different aspects at those times. So in April, you can see how the initial COVID lockdown impacted us. We had very few referrals at that time. And then we were able to improve through our different engagements. However, in July and August, during our first wave, that's when our referrals dropped again. But we made some more improvements as clinics and CBOs functioned better after that initial wave, and we had further engagements. In October, there was a decline in performance due to some of the overseas partners changing their areas of support, so we needed to rebuild relationships and processes in those areas. And earlier in this year, we've made steady progress, as you can see in the months of 2021, with a lot of different engagements with relevant teams. And for us, the key factors that supported this improvement, the one was around creating platforms at all the levels of care to be able to have interactions between the facility and community teams. This helped to drive the activity at the different levels and adapt according to the need of that particular area. We also saw that the mapping needed to be done quite regularly. It's definitely not a once-off activity. As things change and partners move around, new team members come and activities change as well. And then key for us was also trying to support our community partners being able to attend our facilities on our care days for children and adolescents and their families. And in this way, they were able to directly build relationships with our facilities, with the patients themselves as well. And this enabled referrals to take place directly to the community organizations, increasing the linkage to their services. Next slide. And then lastly, I mentioned the case conferencing, and this really puts together the efforts and the support that has been given to some of our clients who have more complex situations. So this example is of a young boy, a 7-year-old, who's living with HIV and was taken care of by different family members, as both of his parents were not able to take care of him for different reasons. It was found that he wasn't attending school, he also wasn't accessing the social grants, and the household was really struggling with limited income. So he was identified at one of our health facilities, and then through the processes that I've explained, he was referred to one of the community partners and managed then through this case conferencing approach. And as you can see from some of the services that were rendered to himself and the family, they really do cut across the different factors that affect retention and adherence. So he was offered different types of counseling, able to enroll in school, offered some material and food support, and also assisted to apply for a social grant. So you can see the case conference really bring it together and help with retention in patients. I think I'm on the last slide. Next slide, thanks. So just in conclusion, in our setting, we were really able to bring together the processes. Our improvements that we still need to make to reach more clients is to ensure that all facilities are engaging with their partners, and when they do start referring, that they refer more children, so that all of our CL-HIV can be accessing this type of care. We also need to improve on our community to facility referrals, and then very important for us to build sustainability. So our recommendations are on the slide, but they really are about having a champion, having continuous engagement, and adapting as needed to offer more support to our young people. And thanks, I'm out of time, but just to acknowledge the different teams and our funders who generously support our work. Thank you so much.
Thank you so much, Carol. Over to you, Malundu, for the last presentation at today's session. Thanks. Malundu, if you are speaking, I cannot hear you.
Good afternoon, Leader.
Hi, Melinda. Okay,
are you able
great.
to hear me now?
Yes, I am. Please go ahead. Thanks.
Thank you. So, like Leader has already said, my name is Malundu Mombalanga, working under Right to Care Zambia as the regional coordinator under HIV testing services. So my presentation is on the retention of children living with HIV in the northern region of Zambia. Next slide, please. So that just shows the outline of my presentation. You can go to the next slide. So as we know, pediatric HIV remains a concern across the globe, with children disproportionately affected by the HIV epidemic, which is compounded by poor case finding among children. So in the northern region of Zambia, there are about 17,214 children that are living with HIV. As a program under Right to Care, we have managed to reach out to a total of 7,169, leaving a gap of 10,045 children in this age band that need to be reached with testing services. And I think we're on the right trajectory as efforts have been made from FY20 first quarter. Next slide, please. So having seen this as a problem, a retention strategy was developed, the issues that were surrounding retention of children that were living with HIV. This retention strategy involved training who we call retention counselors that are and adolescents remain on treatment. And this actually deal with the children that are at high risk. We all know that children born from an HIV positive mother that are on treatment, and adolescents as well as miss an appointment and need reminders as well as proper management for them to remain on treatment. Next slide, please. Okay, so looking at the methodology, the first part was identifying the very important clients who I have already explained, include adolescents and children that are living with HIV. And these are at risk of missing appointments. And then the total number that is at a facility, a district, or a province is ascertained. After this process, there was the assigning of these children to the retention counselors, who are allocated a maximum of 50 clients at a certain period. The 50 clients include other categories that I have not mentioned, but these also include children to manage at a certain point. And this is all dependent on the total number of children. And then the retention counselor manages these children and adolescents with their biological mother and caregiver for the reminders of appointments, and also ensuring that they are stable on treatment. Immediately they are initiated, there is cohorting of the mother and the pediatric or the caregiver to ensure that there's adherence. After that, there's continuous contact of these pediatrics and children and their caregivers from the retention counselor. This is done through phone calls, and then the outcomes of these interventions, those that return for a clinic visit on the scheduled date, and those that come after, just to ensure that any challenge that is surrounding these particular clients is addressed. Next slide, please. So this looks at the successes and challenges that we encountered. So through the introduction of retention counselors and the retention package,
Malundu, I think we lost you. Maybe we'll just wait a minute to see if Malundu can reconnect.
then
Okay, I think she dropped off. Let's just see if she can reconnect in a minute. Hi, Malundu. Can you hear me?
Lida, are you able to get me?
Yes, I would just suggest to turn your camera off. Maybe that will help us hear you better.
Not a problem.
Okay, thank you.
Doing that. Okay, so I was explaining to say part of what contributed to the increase in terms of retention was the allocation of the very important clients to the retention counselors, where we saw there were two areas actually that were increased. There was the increase in the number of clients that were being managed, as well as the number of facilities that had retention counselors, as well as the number of cases or clients that were actually being managed. So the actual increase was from 14 to about 52 reporting sites, and 71 to about 186 retention counselors, each managing a maximum of 50 very important clients. The success also is attributed to successful appointment reminders through caregivers, which were using phone calls and home visits. There was also the increase of TX-New from 257 through family indexing. And the same day appointments with the caregivers also contributed significantly to improving retention. Next slide, please. So looking at the challenges that we encountered, for the children that missed appointments, some of the reasons that actually attributed to this were the economic activities that their caregivers are involved in. So in the northern part of Zambia, there's a lot of fishing, farming, caterpillar picking, which affected appointment attendance. For those that were on 3 to 6 months MMD, only children who are stable, those that have a suppressed viral load with good adherence, are dispensed, resulting in less children on MMD because of this qualification. And that's the challenge that we faced. However, what we plan to do, on the next slide, please, is to ensure that we increase the number of children that's on multi-month dispensing. Currently, we have 1,420 below 3 months, 1,707 between 3 to 5 months, and 1,155 on 6 months. So we want to ensure that 95% of children who are on treatment are on MMD. Other than that, we plan to train and mentoring of clinicians in pediatric management for the purpose of retention. Implementation of mother-mentor models or supported sites to improve retention is also one of the next steps that we actually plan to take on. We also plan to scale up retention counselors in all sites. So every counselor is potentially a retention counselor, but we want to see that this is done more effectively and efficiently by ensuring that each and every site that is being supported under Right to Care manages the clients effectively through cohorting of children with their caregivers. And lastly, we want to ensure that there's continued analysis of second and third pickup of drugs of newly initiated children, simply because second pickups are usually good. The third pickup is where we have clients falling out, but monitoring the second and third pickup coupled with the retention counselor management is likely going to help us increase the retention of children. Next slide. I think that's my last slide. I would like to say thank you to USAID, Ministry of Health and Right to Care for all the support and the opportunity that has been rendered to me to actually do this presentation. To my co-authors and contributors, Dr. Sadoki, Dr. Benchira, Mr. Frank Shiroa, Dr. Chesela, Dr. Constance Waza-Kinge, and all the Right to Care staff. Thank you very much.
Oops, I was on mute. Thank you so much, Malundu, and to Carol and Hamid for all your great presentations. I think we can go ahead and move on to the Q&A section of today's session. We have about 16 minutes. So maybe we can go ahead and start with a question for Malundu, since I see Hamid and Carol have responded to some of the questions in the chat. Malundu, there's a question from Rose asking, can you help us understand the relationship between prevention and retention of CL/HIV on treatment?
Could you please repeat the question?
Yes. Can you help us understand the relationship between prevention and retention of CL/HIV on treatment?
So prevention probably has to, when you look at retention, we are dealing with clients already that are on treatment. And in this case, we're talking about children who we want to ensure do not miss their appointments, who we want to ensure are virally suppressed, who we want to ensure stay positive, as well as remain on treatment. When we look at prevention, we are probably, in this case, looking at ensuring that the children, obviously, that are born from mothers living with the HIV do not get infected or are not born with the virus. So I see it dealing with children that are already born positive and children that are not yet born, as well as children that are born from positive mothers that are not positive. So in terms of retention, we want to ensure that those clients actually remain on treatment, do not miss appointments, and are virally suppressed. And there's their lives are elongated.
Great, thank you so much, Malundu. And maybe I can ask Hamid to answer one of the first questions asked in the chat by Olympia. I see your answer in the Q&A chat box, but maybe you can expand on it if you'd like, because I know this is a very important subject about sustainability. So Olympia was asking what investments go into the Mentor Mothers initiative and how do you ensure that it is sustainable?
All right, thank you, Lida, and thank for the question, Olympia. Like I responded, Mentor Mothers, this is a lay cadre. These are the mothers who benefited from PMTCT program. So we have employed them and we have built capacity on them for them to be able to communicate to our potential clients, because these mentor mothers, they've received PMTC services, so they can communicate and share the experience by heart. Thus they become role models to our clients, and they can even understand some of the challenge because they went through the same path. So as mothers to mothers, we have already advocated this cadre to the national level because we have community cadres in the country. And what we have been advocating is for this mentor mothers to be recognized among community cadres, which are lay, so that as we phase out through donor funds, the government should be able to absorb these high-skilled lay cadre. And currently, they are shifting from being lay, now they're becoming more professional because they are able to do a lot of things. So our role has been more advocating because we really want this cadre to be sustainable and remain in the country to support elimination of mother to child transmission.
Thank you so much, Hamid. And Carol, same to you. I see you answered this question briefly in the chat, but if you'd like to expand. Rose asked, are the OVCs discussed during the case conferencing present during the sessions? Sorry, or are the orphans and vulnerable children discussed during the case conferencing? So please feel free to respond.
Thank you. Yeah, I answered that one. So generally they haven't been. It's mostly the community and facility-based staff that come together and discuss the case. I think it would probably be ideal if some of them could participate, depending on the circumstances. And I just wanted to add, if I could, around the prevention and retention. I think they're also closely linked in that the factors that are affecting the prevention, different forms of prevention, mother to child or PrEP or any others, just primary prevention, you know, the same factors would be affecting the prevention as well as the retention. So we need to look at them holistically, which is quite an interesting question. Okay, thanks.
Thank you so much, Carol. There's another question, I believe by Rose, asking, do mentor mothers and retention counselors work at the same clinic? I think either Hamid or Malundu can answer that.
Malundu will add more because from us, we don't have retention counselors, but what I can share is the same mentor mothers. They're almost playing as a role as retention counselors, because we have mentor mothers who act as case managers. They take a client as a case. They pay attention to this client. They stratify the risk on this client. So if the client is a high risk, there are approaches to rectify that. And if client falls at a low risk, there are strategies to maintain that. So they act as both retention counselors and still they hold back their position as mentor mothers to support retention of our clients into care and treatment. Thank you.
Great, thanks so much. Melinda, did you want to add anything to that?
Yeah, yes, I do. So actually, when you're looking at retention counselors, those are full-time working from the clinics. When you're looking at mentor mothers, you have clients also playing a participatory role towards their fellow caregivers or their fellow mothers. So they do not work full-time at the clinic. So it's a combination of the two. So we obviously want to encourage a mother who's been through a certain situation with her child who is living with HIV, or their unborn child, and they're taking all the prevention methods of pre-exposure prophylaxis to help the next person, or be a person who's in that situation that the next person is in. So that's what I can add. Thank you.
Thank you so much, Malundu. We have about 9 minutes left, so maybe we have time for 1 or 2 more questions. I see a new question in the chat for Carol. Are staff at the clinics very open to these referrals to community OBC partners? Did you need to do anything to ensure their full participation?
Yeah, thanks for that great question. So what we really needed to do was build the relationships at that facility level so that the facility staff could get to meet the community staff directly and really know what they do and know their activities. So that really helped. In speaking to one of our facility staff members, they said that what really worked for them was knowing that themselves and the community partners were on the same page. You know, they were all trying to do the same thing. And they really saw the benefits. So I think once the facility staff see the benefits and they see the impact that that can have on their patients, then that can really help. One of the challenges we saw was that in some cases there were more than one partner supporting one facility. And this did become a little bit overwhelming for the facility because they wouldn't know who to refer to. And that's where the mapping came in. So really being clear about which patients to refer where or how to do it so that it was easier for the facility staff. Thanks.
Great, thank you so much, Carol. I'm not seeing many new questions in the chat, so I would like to invite all the participants today to ask some last questions if you would like to. Okay, I see a new question. There's a question on sustainability which was not fully answered. How can ministries of health be supported to absorb these cadres into their systems for sustainability? Hamid, maybe I can direct this question to you first, and if Carol and Melinda want to add on, that'd be great.
All right, my colleagues will add more, but one of the approach is, yes, one, we advocate for these cadres to be recognized. Once they've been recognized with their efforts, because we have to present evidence why this care is important to still have in a health system. So once that we've been managed to do that, but also we share out the concept of sustainability, saying in this effort of eliminating mother-to-child transmission, for our case, mentor mothers, this cadre can do 1, 2, 3, 1, 2, 3, but their presence is tagged with this type of cost. In a small scale, as a ministry, what can you budget in a small scale? What can you cover to start with? So that time to time, as the donor pulls the funds, the government can come in and add, but it only comes when the government has fully understood the roles and the importance of this care. And that's what we are doing as mothers to mothers in Lesotho, to advocate, to make sure they really, the work that is done by mentor mothers is highly appreciated by the Ministry of Health, so that the Ministry of Health can see the importance of absorbing them into their system. And they should know some of the costs that are tagged with them involving mentor mothers. So it's a work in progress. Hopefully in 5 years to come, they can be absorbed in a health system run by Ministry of Health. Thank you.
Thanks so much, Hamid. We only have 5 minutes left, but Carol or Malundu, do you want to quickly add anything to Hamid's response? If not, that is
Go for it,
perfectly
Melinda.
okay.
I do have something to add. That's thank you. So on my side, I think for the referrals to community partners, it's slightly different. I think it's really about capacitating our local CBOs. As some of our partners, that is their model, so that when the funding changes, they are able to implement directly themselves. And then from the facility side, it's actually really about using our existing facility-based staff, particularly nurses and counselors, and getting them to refer directly rather than trying to bring in a new cadre of staff. That would be for the OVC referrals. Thanks.
So from my end, I think the best way to ever solve a problem or come up with a solution is through the people that are actually involved in a situation. So this has to involve the Ministry of Health, as well as the local leadership that in the areas where we are operating from. So working together, we are able to come up with sustainable measures and approaches that are going to be actually put in place. And the best time to start working on something is now, and not when the local partner is absent or once they have gone to hand over. So it begins now. And I think it's one way in which this can be done. And it's one way in which right to care is actually working in as we have implemented the new project. So I think that is very, very helpful in that way. Thank you.
Thank you, Malundu. And I think we are at time for all the questions we can take for today's session. Thank you for all the participants and the panelists for presenting and for the audience for tuning in. I just want to reiterate the 3 key takeaways for today's presentations. One is mentor mothers help mothers achieve viral load suppression, improve outcomes for HIV-exposed infants, and also confront stigma. 2, a biomedical approach alone will not get us to 95, 95, 95 for children and adolescents. It takes community collaboration as well. And 3, high-risk children and adolescents benefit from a case management approach. So I think that's it for today's session. I would like to ask the presenters to maybe